patient does well on FOLFIRI bevacizumab. Now zip through to February 2017, the patient's starting to feel somewhat lousy, not feeling too good. Scans get repeated. The patient has a couple of new nodules in the lungs, and also the rest of the disease seems to be progressing. The question is, what do you do? What do you do now? The patient has failed FOLFOX bevacizumab in the first line, FOLFIRI bevacizumab in the second line. This is a right-sided tumor, RAS wild type, BRAF wild type, microsatellite stable. So what do you do now? And this discussion goes on every day in our clinics. We have three options for this patient on the right side. We can introduce EGFR inhibitors at this point, or we could go to the other two oral agents, regorafenib or TAS-102. There's no data that tells us what to do at this point. The discussion across every line of therapy should always include the option of no treatment. Every patient should be presented with the option of, this is what treatment helps with, and these are the limitations of the treatment. So I have, in clinic, I have my discussion the first day I meet the patient, even before we start first line, about the importance of maintaining quality of life and supportive care. And the overwhelming majority of the patients will go through 3 to 4 lines of therapy. So we have to think about how to optimize the care for those patients. At this point, the discussion goes about EGFR inhibitors, regorafenib, and TAS-102. Since this tumor is RAS wild type, I tend to offer patients the opportunity to go on EGFR inhibitors in the third line. Although again, one could argue that on the right side, there hasn't been any benefit, but it's mostly being shown in the first, second line, not as much in the third line. A consideration for EGFR inhibitors in this line of therapy. So the patient would go through EGFR inhibitor, typically continue the irinotecan, so irinotecan plus panitumumab or cetuximab, and following that, then we have two options, regorafenib and TAS-102. They're oral options. So they're oral pills, and they're a little bit different. One is a multi-kinase inhibitor that targets multiple facets of the tumor. The other one, TAS-102, is essentially a cytotoxic agent. It's a chemotherapy drug that belongs to the superfamily of fluoropyrimidines. It's not 5-FU or capecitabine. It's different. It works when the others fail because of its biochemical composition, but it's a chemotherapy drug. When we look at the cumulative knowledge with regorafenib or TAS-102, we don't have any studies that actually compared the two head-to-head. So we don't have that data. Historically, from all the studies we have, they seem to derive very similar benefits in terms of survival and progression-free survival. So this comes from the CORRECT and the RECOURSE study. Both of them were studies that had patients pre-exposed to all chemotherapy regimens, all biologics, as indicated. There were two other studies that give us somewhat of a hint about perhaps the benefit of each one of those agents in less pre-exposed patients. These were Asian studies, CONCUR and TERRA, CONCUR with regorafenib and TERRA with TAS-102. And interestingly, in those studies, historically at least, when you compare them to the more pre-exposed patients, regorafenib seems to do much better in less pre-exposed patients. TAS-102 doesn't seem to care. Additionally, we have only a subgroup analysis in a study, in the RECOURSE study, that suggested that if patients were pre-exposed to regorafenib before TAS-102, they do equally well as those that were not. Meaning, in other words, pre-exposure to regorafenib did not seem to compromise the chances of TAS-102 to work. Now, these are hints. I mean, ultimately, unless we compare them head-to-head, one cannot make a scientific conclusion. The toxicities are a little bit different. Hand and foot syndrome in one, hematologic toxicities in the other one. GI toxicities are about the same in the two, if we believe one study that was published in colorectal cancer. that was mostly retrospective experience with both agents, and fatigue was about the same in 2, which probably speaks to the stage of the disease more than the drug, although both drugs add some level of fatigue. Regorafenib adds fatigue probably quicker than TES 102, but TES 102 does induce that. So in my clinic, I tend to, for most patients, to proceed with regorafenib first and then leave TES 102 to later, although there are some select patients, say their liver function tests are a little bit higher than desired. The patient's performance status is 2, borderline 2 plus, probably consider TES 102 for those patients. But for most, proceed with regorafenib first. For this patient, what we've done then, we've started with FOLFOX bevacizumab, proceeded with FOLFIRI bevacizumab, and maintenance regimens in between. Then went on irinotecan and cetuximab. And after that, still had a good performance status. We proceeded with regorafenib for 4 months. And after that, the patient decided to proceed to hospice.